some of the drugs that we use, different blocks that we do. Hi, come on in. The reason that I think maybe it's good for you guys to know, to be a little bit more familiar with it, is just because I think because of the change in our practice model now with the CRNA and the anesthesiologist who are out of the OR, it makes it a little bit more efficient to do some of these procedures before a patient rolls back into the operating room. A lot of the surgeons, they're happy if the patients get a block, or if we do these procedures, and it's good for the patient, but some of them historically have been kind of reluctant to do that just because it takes time. It takes, they have 5 or 6 cases in the operating room, and it takes about maybe 20 minutes for each one. Like, if you do a block, and if they have a couple of these, then it kind of, it prolongs their day, and it makes the OR less efficient. And then sometimes, if it's a really severely ill patient that has a lot of comorbidities, and we want to avoid general anesthetic, so you can actually do some of these surgeries just with a block, but you have to do it ahead of time because it takes about a good maybe half hour, 40 minutes for the medication to set up, and for the extremity to get numb if you want to do that. So that's another reason. Although most of those patients are actually in-house, which are good because they just come from upstairs. We have them come down to the holding area a little bit earlier, and then we block them over there. But then there might be a case where somebody comes in from home and they need some kind of surgery and want to avoid general anesthetic if it's possible. So and then also for the strong for surgery. So we're doing more of those cases, and it's actually been recommended that we can do if you can do these neuraxial blocks for those guys. With some couple of the new joint oncologists, I don't know if you guys have known them yet. It's McCormick and Westhoff, and they just recently talked to us about that some of their patients, they would like to do the same thing. Although their numbers are not very high right now, I'm not sure when their numbers will pick up. They're here just a couple of days a week, and even that they're not operating a whole lot at this point. But down the road, we might get busier with them. So that was another reason that we're going to do this. So the learning objectives, we're going to just sort of talk about overview of regional anesthesia, some risk versus benefits, local anesthetics. I was going to talk to you guys about just different medications, some of the signs of toxicity, dosing and whatnot. And then overview of just a few of the blocks, just in general, what they are, what they entail. And then this last part, I know I've talked to Jim about this, and you guys are super busy up here. For the majority of the time, our goal is to have maybe one of the anesthesia techs be available for us if you do these blocks, so they can come and help us. But as we're getting good at these and using ultrasound, you can actually do some of these blocks in about 10 minutes, 10-15 minutes. So there might be occasion that if everybody's busy or there's only one anesthesia tech, if we might ask one of you guys to give us a hand. Hopefully it won't be often, but we're going to try to minimize that. So regional anesthesia pros. Basically, it's kind of obvious. It's probably the best way of relieving surgical pain. It's actually in the anesthesiology is a very new profession. It's only about maybe a couple of 100 years old. If you want to compare it to other areas in medicine, the first anesthesiologists were basically surgeons. They put some numbing block, and then they went ahead and did the surgery and went on about their business. And then even before that, the best surgeon was someone who was like really fast. Basically, so they could do the surgery and the patient wouldn't lose a lot of blood, and that was probably before cautery and whatnot. But for the most part, now that it's a profession. Unfortunately, it's almost because it has become where it's more and more getting kind of a specialized area where some of the anesthesiologists are all they do is just push drugs, put them to sleep, and then wake them up. Push drug, put them to sleep. So if you can use these multimodal regimen, whether it's a regional anesthesia, given different drugs, and that usually that's good for the patient. It decreases some of the side effects of opiates, and it improves patient satisfaction. In terms of bigger operations like these thoracotomies or abdominal procedures, it makes it a lot easier for us to ambulate them a little earlier if you have an epidural. So those are some of the reasons. And then the cost effectiveness, this basically there's been a lot of published studies, mostly in the anesthesia literature, where they've looked at areas where they do a lot of outpatient surgeries, and when they do a block, they can get the patient out of the hospital a lot quicker. They don't have less time in the PACU, less time in short stay. So those are the pros. The cons, again, it's a skill. Some of the anesthesiologists are less enthusiastic about it. It's operator dependent. Sometimes if you do more of these, then you'll get good at it. You can decrease anxiety to the patient when you're explaining it, and it takes less time. So the more you do it, the more you get good at it. And then at the same time, sometimes let's say there's 40 anesthesiologists in our group. Not everybody's fast out with these blocks, so it is operator dependent. The added time required, that's another issue where, like I said, a lot of the surgeons don't like it just because it takes a little bit of time for the block to set up. A lot of the patients, usually when I'm trying to tell them about a block, and I'm really enthusiastic about it, but then if they have real anxiety, they just want to go to sleep. So so you have to actually explain to them what it is and how beneficial it is. And then each one, it's a procedure. So each different block that we do have these risks that are associated with it. And of course, the bigger one is the risk of local anesthetic toxicity. Just because to do these blocks, we have to give a larger volume in a short amount of time. So local anesthetics, in general, basically what it does is, as a class, all of them, they prevent action potential to go to propagate along the nerve. So what they do is they block the sodium channel, and they keep the sodium channel in a fixed, open position. So when there's an action potential because of the stimulus, it doesn't meet the threshold. So then it basically stops from sending the information down the axon. They're basically two classes. So there's amides and esters, basically depending on their structure. So you have the aromatic ring, and then you have an amine group, and then to combine those, you have a linkage in between them. So we have the esters they have an ester bond. The amide has an amide bond. So basically, it's the easiest way to learn it is that the esters have only one eye, and then most of the amides have two eyes, like lidocaine, bupivacaine, mercaptan. The esters are procaine, chlorprocaine, cocaine. So novocaine is a brand name for procaine. Hi there.
Hi there.
So that's one of the differences. The other difference is that esters, the way they get metabolized in the system, esters are metabolized by an enzyme esterase. It actually they get metabolized within the plasma, so it's not related to any kind of liver organ or kidneys. Whereas the amides, they have to go to the liver for metabolism. So if one patient is allergic to one, you can always use another class. Historically, the esters, when they get metabolized, they have a byproduct called para-aminobenzoic acid, or they call it PABA. And a lot of times patients are allergic to it, and it's actually the byproduct that they're allergic to it. So, and that's common because like in a lot of the dentist offices, they use novocaine, which is procaine. So they might be allergic to that. Some of the other allergies, of course, you guys know, is they may talk about racing heart rate when they get a local, so they say, oh, I'm allergic to lidocaine, but that's probably related to the epinephrine that we have mixed with these. The way we calculate the dose is basically each local anesthetic comes with a strength, like a percentage, like 2% lidocaine, 1% lidocaine. And the way to get a dose of it is basically you multiply 10 by that number. So 0.5% Marcaine is basically 5 milligram per ml. And each one of these, there's a maximum amount that you can give to a patient that is safe. Might be my next slide. Oh yeah. So for example, lidocaine, the max is about 5 milligram per kilogram. If you mix epinephrine with it, epinephrine causes vasoconstriction in the area. It slows the absorption, so you can actually get away with a little bit larger dose, which is 7 milligram per kilogram. And same thing with Marcaine, which is bupivacaine. The max for that is about 2.5 milligram per kilogram. So Marcaine is the longer acting local anesthetic. What makes it longer acting is that it has a higher a protein binding capacity. So that means that it basically stays within the plasma. It binds to the albumin and all those other proteins that are in the blood, and also in the tissue. So it lasts a lot longer. To calculate the dose, so you just basically, the patient weight gets multiplied by the maximum dose, and that's how we figure out. In terms of, like, let's say a lab chole, nowadays they use a lot of local anesthetics. So sometimes they come to you guys and they say, oh, they use a whole 60 cc's of local. So what they do is they make these little trocars, and then even at the beginning of the case, even before they start putting local. So in a different fascia, which makes sense. Dr. Gramstad, he does a lot of his total shoulders now without a block. So that's what he does. He, as soon as even before he makes the incision, he draws a line, and then he starts infiltrating the skin with it. And then in each layer, he puts like more and more and more and more. So he dilutes the amount to, like, with some saline. So he does give, like, let's say maybe 50 cc's or the maximum for Marcaine, but he kind of dilutes it in a larger volume, and he kind of injects it, throughout the block, throughout the case. So
you said that was without a block?
He does them without a we often do an interscaling block if it's a total shoulder.
Mm-hmm.
So he does them just with general, like somebody like Dr. Way, he likes his with we like to do block for his cases. The Longview guys, we usually do block for them.
But when you say that they infuse it without a block, you mean they just infuse it in the tissues instead?
Right.
Okay.
Right. So they do like so they don't necessarily find on each nerve and put medicine along the nerve. They basically they infuse in the subcutaneous tissue or in the muscle layer or whatever that they decide.
Okay.
Yeah. So that's how you sort of figure out the max dose. You basically you find out what the total safe dose is per patient's weight, and then you divide that by the concentration of the medication, and that gives you like a volume. And so in this case, this is a 4% Marcaine for a 70 kilogram patient. They can have up to 70 cc's, which would be safe. So this is not intravascular dose. So it's basically a dose that they inject into the body. Of course, if you give all that intravascular, that's
problem.
It's a toxic process. Yeah. And actually, we've had lots of success for these guys. The reason that Gramstad told us that he doesn't like it is because he doesn't like his patients to have no pain at all, and then like block wears off, and then they have pain. So he likes him to have pain all throughout the case. But anyway, I mean they're doing okay. His patients are doing fine. Unfortunately, that's one of the drawbacks when we do these blocks. Like you'll say, the first case of the day, you do them at 7 a.m. or 8 a.m. So by 8 p.m. or 9 p.m., they run out and they're still awake. But if you do some of the afternoon cases, and it's like 2 a.m. when the block wears out. So if they haven't had any medication, then it makes it like a rough night for them. So local anesthetic. So in terms of toxicity, so it happens if it's an overdose, like we talked about. If you give a a little old lady, you give a lot of it. In terms of you have these hip fractures and whatnot. So they can get overdose just because you're injecting it in the correct area, but you're giving them a larger dose, based on their weight. Or if it's an intravenous intravascular injection, so that's another big issue. The intravascular injection has gone down. The incidence of it has gone down considerably over the years because nowadays we use an ultrasound. Even though the risk is not zero, of course, because often our goal is to see when we're doing an ultrasound block to see the whole needle as you go in, but there's always risk for us not to be able to see the needle. So that risk has gone down considerably. But and most of the accidents were happen in terms of what if there was any kind of severe incidents, it has to do with the intravascular injection in terms of patient complication. So the signs in terms of when they get absorbed, when they get the local anesthetic absorbed into their system, and they get basically an increasing blood level, right? Any kind of stuff injected into the body, they sort of slowly the blood level goes up. So in terms of the side effects of it, it has to do with CNS and also the cardiac. So those are some of the vessel-rich tissues, and also some of the areas where that has a lot of fat in them, especially the brain. So the medication being lipophilic, so they like to be in fatty tissue. So that's what happens if you get an overdose. So in terms of the side effects, the CNS comes in a lot faster than the cardiac. So the side effects are like I don't know if you guys have done a lot of OB, or not OB, but whenever we do an epidural, when we do a test dose, some of the questions that you ask is, are you feeling okay? Can you wiggle your toes? And then the next question is, are you hearing any ringing in your ears or any funny taste in your mouth? So those are some of the early signs of CNS. So they get like a perioral numbness. They may get a metallic taste in their mouth. So those are some of the early signs, and that happens if you inject some local anesthetic, basically in a blood vessel. So the reason for that is you're basically injecting a larger dose right away in the bloodstream, which we often we try not to do, although we do it in the operating room because of when we give lidocaine right before we mix it with propofol. Some patients are very sensitive, so as soon as you give them the lidocaine, they say, I got this funny taste in my mouth. So that's basically what they're feeling. When the dose goes up higher, especially if it's on the on the toxic range, they get muscle twitching, they get auditory and visual hallucination, and of course, as the dose gets higher, they can have full-blown tonic-clonic seizure. They can become unconscious and respiratory arrest. So these last areas, these are the ones that are related not just by infiltration, but actually intravascular injection. If it's an intravascular injection, and so these are some of the first signs that the patient may have, and then as the cardiac signs comes in later in terms of these are sort of hypertension, tachycardia, and as the dose goes up, or if toxicity if it's a higher dose, they can actually affect their cardiac output. So they can have decreased contractility, hypotension, sinus brady. They can have some ventricular dysrhythmias or even a circle arrest, and that's not a. So these are basically the one that you actually know that it's going to be a full-blown local anesthetic toxicity. When we do blocks, there are some blood vessels around them. Then some of these risks, like I said, has gone down considerably because when we look at ultrasound, and most of the nerve bundles, in order to find it, you actually want to find you want to find the artery because that's the most visible thing that you see on the screen, and then you see, oh, there's a nerve right next to it. We used to, before ultrasound, the way we did nerve blocks were you would use either a nerve stimulator, or a lot of times you would, I guess in the maybe 20 or 30 years ago, they would use a needle and then they would actually hit a nerve, and then the patient would get a paresthesia, and that's how they would know that they're near a nerve. So they would say no paresthesia, no anesthesia. That was a good thing. So when we do these blocks, the amount of drug that gets absorbed into the system has to do with the area when we do the blocks, how much blood vessels are around the area, and how easy it is for the medicine to get absorbed. This is in order of, I guess it would be descending order in terms of how much of the medicine gets absorbed. So intracostal blocks are blocks that get the medicine gets absorbed a lot faster. So they have the highest amount of drug concentration in the blood vessel after injection. Even though you're not injecting into the blood, you're injecting into the surrounding area. But since the intracostal area, there are a lot of blood vessels underneath each rib. There's basically vessel-rich area. Caudals, epidurals are next. Brachial plexus is down in the order in terms of how much of the medicine gets into the systemic circulation. Sciatic and femorals are lower, and then subcutaneous is probably the least, just because there's not a lot of blood vessels in the subcutaneous tissue. So in terms of safety, subcutaneous is the safest. Sciatic, femoral is next safe. Brachial plexus is next safe, and then the epidural and the least safe is those intercostals. And actually, intercostals and caudals, we don't do those here. Caudals are used mostly in pediatric population. Intercostals, we do them for sometimes for trauma patients at the other hospital. If they have a lot of rib fractures, we do those. And for thoracotomies up here, if we do any, we don't do a whole lot, but if we do any, we just put a thoracic epidural for those. So next I was going to just talk about different blocks themselves. So there's two areas, just this, the nervous system. You have the central nervous system, and then you have the peripheral nervous system. So neuraxial is basically CNS blocks that are epidural and spinals. Epidural, just from the name, epi means above, so you're staying above the dura or outside of the dura. If you look at the picture, so when we do an epidural, the epidural needle itself is a blunt needle. It's called a Tuohy needle. So we put the needle in, and then we actually use a loss of resistance syringe. Some people use a little bit of saline in it. Some people use air. So you put the saline or the syringe at the end, and you go in, and you basically go in through the skin, subcutaneous tissue, and you're against this yellow ligament, which is ligament flavor. And then that's a very, very tough ligament. And with the needle being blunt, so you're actually feeling resistant, and all of a sudden you feel a pop. And that's how you know you're in epidural space. So epidural is not a space itself. It's basically a potential space. It's right in between the dura, which is this silver lining around the spinal cord, and then the ligament flavor. So in between the two is this space that are within it. There's like fat tissue. There's some blood vessels inside. So that's the epidural space. So once you get into that space, then through that needle, you put in a teeny tiny catheter in the space, and that's basically what an epidural block is. So once we do that, we give a test dose, like I said, we often do, and the test dose that comes in the kit, and it's the standard test dose. It's a 1.5% lidocaine. It has a little bit of epi in it, and the typical test dose we give 3 cc's, and that gives you about 45 milligram of lidocaine. So we calculated the dose for lidocaine was like 5 milligram per kilogram was the max dose. So this is a very, very small dose, for in terms of the toxicity. But it tells us what if this is a spinal block, or if it's a intravascular injection. Because when we put a catheter, we don't know where the catheter goes, essentially. We just want to make sure that it's not in the in the blood vessel. And then they get a small dose of epinephrine, which is 15 mics, and that basically gives them if it's an intravascular injection, then they get that funny taste in their mouth, or they get the palpitation, whatnot. I just put a few things about epi concentration in terms of how you calculate the dose. The 1:1, which is a code dose. Basically, it's 1,000 milligram and 1,000 ml. That gives you 1 milligram per ml, and then these are the other concentrations. So the test dose that we have is 1 in 200,000. So it's very, very small amount of epi. It's 5 mics per ml. So in that 3 cc that we give, it's about 15 mics of epinephrine. So that's enough to tell us if it's an intravascular injection. They get some tachycardia. For epidurals, we often just use a pulse ox upstairs on LMD or up here, or when we do these. So you can tell if they're having any kind of side effects. And for the most part, if it's an intravascular injection, the patient basically has those early CNS signs. They get, I got funny taste in my mouth, or I get a little bit of ringing in my ears, and that's how you know. And then the other thing that you want to rule out when you do an epidural is, of course, you want to make sure that the epidural catheter is not in the spinal space. So this 45 milligram of lidocaine is enough dose that if it's in the spinal space, they would get a numb extremity. They won't be able to move anything. So they would get a spinal block. So as long as, that's another, once we do the epidural, we ask them, hey, can you move your legs? So as long as they can move everything, that means that the catheter is not intravascular, and then it's not in the spinal space, and then it's in the epidural. For the cases that we do these, so that's all that they're going to get in terms of medication. And for the most part, we use the epidural as a post-op, once towards mid operation, or if you want. I mean, if the medication or if the test has been done towards the beginning of the surgery, they can have a little bit of surgical block even from that test dose, in terms of having a little bit of numbness in this area. The spinal block, which we're not going to do any of these here, just because we do the spinals in the operating room. Basically, so this is a cut cross. So this is the ligament flavum. This is where the needle goes. So remember, with the epidural, we would go in and we get a loss, and you would stay in this area. But whereas spinal, you can actually go through, and you would go through the dura, and you would inject medicine in the spinal space, which is up here. So that would be spinal block, and usually it's a better anesthetic. We do these for total knees. Of course, we do them for C-section all the time. They give an immediate dense block. You can do surgery within like 5 minutes. It's not like an epidural where you have to kind of wait for it to set up. And so those are the advantages of having it, having that. And then a lot of studies have shown that if it's like, let's say, a hip surgery, if you do a spinal, it's even better, because basically the patient has less stress and there's less blood loss. And for C-section, it's better, and it's optimum because the patient can stay awake. So the next thing I was going to talk about was just the peripheral blocks that we do. So the common ones that we do are for brachial plexus for upper extremity, and then the lumbar plexus, which is for lower extremity. Inner scaling is probably the most common one that we do for upper extremity, and then femoral nerve block are probably the most common one, and occasionally we do some sciatic block, which are for the lower extremity. And then these are called plexus. Basically means that they're coming in from the cervical region and then the lumbar region from the spinal cord, and then as they come out, the inner scaling, the name is called inner scaling just because it's between the two scaling muscles. The first one, the anterior, is cut so you can see it, and then they have the middle scaling, and then all those nerves are coming in between. Nowadays, like I said, we use an ultrasound. So when you put an ultrasound probe along this area, you basically cut these, and I'll have a picture of it here, so where it will show basically three hypoechoic dense, like almost like cones. So you see those in ultrasound, and that's where you inject the local anesthetic. The proximity of the phrenic nerve, you can see the phrenic nerve comes along. This is the accessory, and this is the phrenic nerve itself. So sometimes with inner scaling, one of the things that can happen is they may get a hemidiaphragmatic block, or like one diaphragm is not as functioning as effective. It used to be common if we're not doing it with ultrasound, but like I said, with ultrasound, you're using less local anesthetic because you exactly know where you're injecting, and then you try to avoid the phrenic nerve. By the time that happens is usually because we do a lot of these blocks for patients that are going to have a general anesthetic for the case, and then the block is for post-op pain. So usually when they're in the OR, it's really not an issue. But by the time they get the PACU or when they go upstairs, if people are having, let's say someone has really bad COPD, or if they have like myasthenia gravis, some of those issues where they have like weak muscles to begin with. So that would be a big issue. But if it's a healthy individual without any comorbidity, let's say a young guy getting a shoulder scope. So if you do those for those guys, I mean, even if after that one diaphragm is paralyzed, they really don't have a whole lot of subjective complaints. So inner scaling, basically we do it for shoulder, arm, and elbow surgery. The top one is a cadaver picture. The bottom is an ultrasound. Lateral is this way. Let's see. Actually, lateral is up because this is carina, this is esophagus. So this is front, and that's the side. So what you see is you see the artery here, and this is what we look for. This would be like bouncing and pulsating, and this is the three coins that I was talking about. And this picture is right over here, and these are the inner scaling muscles. So this is in between. So it's called inner scaling. We use those for arm and shoulder surgeries. By the time we inject, and by the time if we do the block here, about maybe half hour or so, initially they probably won't even feel anything, and the first thing that they will feel is that they're going to lose some sensation in the shoulder, maybe upper arm, so they will lose some coordination. So the key there is just whatever extremity has been blocked, just make sure they're I guess on that side, make sure that the side rolls up, or they're not getting up or doing anything, because they will have some loss of coordination in the shoulder. In terms of complication, just like any blocks, like I said, there's a risk for vascular injury, local anesthetic toxicity,
and it's normal for them to have pain in their axilla because it doesn't numb their axilla, isn't that correct?
Yeah, for when you do narrow scaling, the area in axilla, the nerve that comes off of the plexus it's a little bit farther out. So yeah, so they can have pain there.
Mm-hmm.
It doesn't. A lot of time it spares the ulnar nerve. So how we have the dermatome, in terms of the arm. So you have C1, C2. So the top of the thumb is C5, and then this is C6, C7, C8, and then P1 is up here.
Okay.
So basically what happens with inner scaling is basically cervical blocks in that C3, 4, 5 area, which is comes into the shoulder, and then so down below. So the axilla is basically like a C8 or P1, so it doesn't go that far, yeah.
Okay.
So that's why the ulnar. So often when you have a inner scaling block, so they won't have any numbness in their pinky, but their thumb might be basically numb.
Okay.
So that's kind of normal.
That's normal.
Yeah, just basically because of the anatomy. The other thing that can happen from inner scaling, which is, again, this is when the block basically sets in, like 2 hours, 3 hours, maybe 4 hours later. It's called a Horner sign, or they get so on the same side, when we do a block, they get like a little bit of ptosis in their eye, where one eye is a little bit, droopy. They get meiosis, which is like constricted pupil. So when you look at them, we're like one eye is a lot smaller than the other one. They may get some nasal congestion. We won't see any of those in the pre-op, but these are usually like when the post-op, when they come to PACU, they may have it sometimes, but for sure, when they go upstairs. And a lot of time that basically has to do with when you inject the medicine. If it's a larger volume, they go up a little bit in the stellate ganglia, which is higher up in the neck, and that's how they get those symptoms.
And it's difficulty swallowing too, and they have a hoarse throat or hoarse voice.
Hoarse voice can happen, right?
It can be difficulty swallowing, so just be cautious.
Yeah.
Yeah.
Oops. Okay, so for upper extremity, I think this is probably the only ones that we would be doing. Occasionally, the brachial plexus, like I said, it comes in here, and then very, very rarely we do an infraclavicular, which is kind of down below, which is infra means below the clavicle. It's in that area whereas the plexus is a lot denser, so you do those for like hand surgery. And so those are the only ones that we would be doing, the interscalene and the infraclavicular. In terms of the process is essentially the same. You would use the ultrasound probe. One would be right around the clavicle, and the other one would be higher up in the neck. For lumbar plexus, or if you do any kind of lower extremity, it's femoral nerve block. So these are done for a knee and anterior thigh, and then if you do a sciatic, which are for the leg, same kind of scenario here. They come off the lumbar area in terms of the plexus. So Dr. Is it Fleischman? Yeah, Dr. Fleischman. So when he practiced, or a lot of places, when we do knee surgery, these total knees, you can do the same block, the femoral nerve block.